Today's episode about eyeballs is brought to you by the Nuance Dragon Ambient Experience, or DAX for short. This is AI-powered technology that helps physicians be more efficient and reduce clinical documentation burden that causes people to feel a bit overwhelmed and burnt out. To learn more about how DAX Copilot can help reduce burnout and restore the joy of practicing medicine, stick around after the episode or visit nuance.com/discover-DAX. That's nuance.com/discover-DAX.
Knock, knock, hi.
Knock, knock, hi. Hello, everybody. Welcome to Knock, Knock, I, with me, your host, Dr. Glockenflecken. This is your one-stop shop for all things eyeball. We're doing a late night session today. And before, what I typically try to do, obviously we're going to get to our eyeball topic here shortly, but usually at the beginning, I like to just rant about something. Sometimes it's a rant. Sometimes it's just talking about what's on my mind. Today, it's a rant. It's a rant because I want to know who is selling my information. I would love to know that. Like I'm talking medically. Like probably there's lots of companies out there that have sold all of our information several times. But from a medical standpoint, explain to me how I can. So I have my home address, but also have an office address where I practice my ophthalmology 4 days a week, full-time for an ophthalmologist. How is it that I can, every week, somehow accumulate a variety of these periodicals, these magazines that are, it's like pop culture for ophthalmology. It's like Scientific American or just like Time magazine. They have these articles. There's no peer review, anything in it. It's just these you just kind of it's something you would look at, in the waiting room before we had smartphones. Every week, to my desk, to my office, I just get delivered these things that I will never read. And there's like 7 or 8 different kinds. There are things like Ophthalmology Times, Retina Monthly, Ophthalmology Manager. There's all kinds of names for them. The Ophthalmologist. I don't know where they come from. I don't know who owns them. I know that within these magazines, I call them throwaways. Does anybody else call them throwaways? They're throwaway journals because they're not real journals. They're just magazines. And I'm not saying they're bad. That's not my point at all. In fact, I will find myself, when the stack that I have at my desk reaches a certain height, I will recycle them in bulk, but I'll take a look at a couple of them. Like what's going on in here? What are people talking about? And it's articles that are written by famous ophthalmologists and that we've heard of that are in academics or private practice, but there's no citations for anything. So they're talking about things within ophthalmology, but it's not peer reviewed stuff here, right? And my question is how I did not sign up for any of these things. And I realize I might just be speaking into the wind here because I don't know if anybody else has this problem. I think they do. I think this must happen to everybody in medicine. Those of you who are not in medicine who are listening to this, probably like, what on earth? Maybe this happens in other fields as well, other industries. Do you just get random mail that you didn't sign up for? It's equal parts mind-boggling and also just frustrating because clearly they've gotten my information, my address, my work address from somewhere. Is it the American Academy of Ophthalmology selling my information, selling my to people? And I don't know. I don't know who's selling it, but it's getting sold and I'm getting mail because of it. And it's just a waste. That's the thing. It like I lately I've been thinking a lot about waste because in ophthalmology we have a lot of waste. We do these, today I did 11 cataract surgeries, and every cataract surgery there's all these disposable things, and it's really, it kind of like eats at me that we have so much waste. It's like I can't even think about the massive amounts of waste in healthcare related waste. It it like it's almost hard to even comprehend. I in my mind I have like Wall-E, the world of Wall-E, right, where there's just mounds, skyscrapers, sized mounds of trash everywhere. It's like, my God, the amount of waste in medicine. So anyway, that's what irritates me the most about all these mailings that I get is just they're just a waste. Like, I'm not throwing it away, I'm recycling it all, but still, it's like, God, can we figure out something else to do? Why are we doing this? And then the other thing is just the content of them. Some of the stuff is interesting ideas and interesting topics, but you have to take it all with a grain of salt, because at the end of the article is the author's financial disclosures, which all of the authors who are writing in these things, I don't know if they're getting paid to write in these things, but they all have financial disclosures, like a lot of them as well. And so it's hard to really take their recommendations seriously because of this. So I read one recently, and it was about there was an article, it was like the feature article was about the possibility of using robotics in cataract surgery, because that's the future. The future is robot cataract surgery. Why? Why, you ask? Because it's efficiency. We have to make it efficient. We have to make it better. We have to make it more precise. You guys, we do 6-minute cataract surgeries. You have cataract surgeons that are doing 25 and a half day. How much more efficient can we get? Like, what? This is not just me being like, oh, I don't want progress. No, my question is, at one point, is it enough? Like, we already have machines, microscopes that help us. We have techniques, we have lasers, we have things. Like, why do we need a robot to do this 6-minute surgery for us? I don't understand the drive for some of these. Like, who is asking for this? What problem is this robotic surgery solving? The success of cataract surgery, how we do it now, is through the roof. Upwards of 96, 97%. What problem are we solving by making a robot that does this? I don't know. And so you get to the end of the article that's all about the future of robotic cataract surgery. Oh my gosh, wouldn't this be so amazing to have like a $20 million robot that can do what I can do, like maybe 30 seconds faster? You get to the end of this article, and the author, of course, is an investor in 3 different robotic companies. So that's what I'm talking about. Like, you got to be careful out there, people. Like, if someone's recommending something to you, whether it's social media or one of these things that you see in some random doctor's office waiting room, like, ask yourself, like, why are they recommending this? Like, don't take anything at face value. Like, do your homework and like know who you're listening to. Like me, like, you can do your research on me. You can verify the things I say. I encourage you to do so because, yeah, I mean, some of I'll tell you all this stuff, and I may not give you all the sources that maybe I should, but part of that's I don't have the time, but I'm also not really getting into like the latest literature and stuff. But I encourage you to do that. Like, it's even the really smart, brilliant people, they'll tell you things that they believe to be true, but they can be influenced by companies that they're investors in. And I don't know. I don't know. And I mean, none of this really matter. I mean, it's not that big of a deal. Like what? So I recycle 10, 10 throwaway journals like every 3 days. It's just annoying. It's just annoying. I don't know what the purpose. Obviously, it's to sell advertising like this. There's so many advertisements in these things. It drives me crazy. But they're with us and they have my information. They probably have my children's names. They probably have my hopes and fears and my social security number and my credit card information. I don't know what else they have, but anyway. All right. That's my rant of the day. The throwaway journals. Tell me how frustrated you are about throwaways. Let's take a break. I'll be right back with some eyeballs. And we're back. It's time to get into some eyeballs. This is a very common suggestion from all of you. We're talking optic neuritis today. And so optic neuritis, inflammation of the optic nerve. That's all that means. So a lot of medical professionals think optic neuritis is like synonymous with multiple sclerosis. Like but it's not. Optic neuritis it's a generic term that just means inflammation of the optic nerve. There's lots of different causes of optic neuritis. It can be idiopathic. That's really common. Or it can be associated with systemic disease. There's lots of different things. It can be multiple sclerosis. It can be syphilis, sarcoidosis, Lyme disease, lupus is another one. So there's just because someone has optic neuritis doesn't mean they have multiple sclerosis. It could just be an isolated optic neuritis event as well. So let's talk about an actual patient, like a presentation of what someone might come in with that has optic neuritis. So, all right, so we have a 40-year-old woman who comes in with cloudy vision in the right eye. So this is going to be a very classic presentation. So she was doing well until a couple weeks prior to coming in when she noticed a gradual decrease in her vision over the course of 3 days. It was accompanied by pain with eye movements. Pain with eye movements. That's like a one neuron arc. Oh, optic neuritis, pain with eye movements. That's because 92% of patients with optic neuritis have some degree of pain with eye movements before they start to lose vision. This is a very common symptom of optic neuritis is pain with eye movements. And they have this kind of dull headache. That's really common as well. Patient also noticed decreased perception of color, like colors were a little bit different in that eye. No other neurologic deficits, which is always something you ask for anytime someone's got a potential optic nerve problem. You're always like, do you have any weakness, numbness, tingling, double vision, headache, all these things. But none of that. And on exam, the vision was a little bit down, about 20/40 in the affected eye. But also, more importantly, the pupil exam was unusual. So this is something I've talked about before. I'll keep talking about it because it's that important. If you are in a field where you will be seeing patients with new neurologic problems, you gotta know how to do a neuro exam. That includes all of you emergency physicians. You gotta know how to do a pupil. I think I said pupil exam. It's getting late, you guys, so just bear with me for the rest of this episode. You got emergency physicians, primary care doctors, ICU physicians. Guess what? A lot of people have to deal with the neurologic system. So please get comfortable with a pupil exam. Know what it looks like when someone has a relative afferent pupillary defect. So our patient here has an RAPD. All right, and I encourage you. There's a great YouTube video out there. Just search for it. You'll find it. It's just a swinging flashlight test. And you're looking for a sluggish pupil, an abnormal pupil that doesn't dilate when it should or dilates when it shouldn't. There's really no way for me to There's no effective way for me to try to teach you a relative afferent pupillary defect verbally like this. You just need to like see it for yourself. So go check it out. Look up videos for it. Really, really important finding. And so here we have this patient, classic story, classic demographic. All right, young woman, vision loss, abnormal pupil exam, pain with eye movements. I am on high alert. Like all the alarms are going off in my head, right? Optic neuritis. The question is, what's causing the optic neuritis? That's what we have to get to the bottom of. Certainly one of the most common is going to be, multiple sclerosis. But again, just because someone has optic neuritis doesn't mean they're going to have multiple sclerosis. All right, so what do we do? To get to the bottom of this, I wanted to mention a couple other exam findings that can come on with optic neuritis. One is called Pulfric phenomenon. Good old Dr. Pulfric came up with this one. I hate eponyms so much, you guys, because now I got to remember this guy's name but there's nothing in that tells me what the thing is that he discovered. But for all of history, for all of eternity, he is going to be the name for this thing. Basically, what it is, Pulfric phenomenon, is when motion of a pendulum appears elliptical as opposed to a linear straight line. So, the reason for this is because the affected optic nerve that has optic neuritis has slower conduction speed in that nerve. And so it's going to perceive motion different than the other eye. And so it's going to look, instead of a straight line pendulum, it's going to look like an elliptical pendulum. I kind of get it, but also kind of don't. So don't worry about it if that was confusing, but it has to do with conduction speed being slower in the affected optic nerve that's inflamed, that has optic neuritis. And also that's I think has limited clinical usefulness because first of all, not a lot of us are walking around with a pendulum in clinic to be able to check good old Pulfric. Man, that guy, he had a lot of things in his bag. But no, I've never even actually seen that. Another one is Uthoff's symptom. Uthoff. God, these eponyms, they're so bad. It's just of course, I would love to have a Glockenflecken sign, but whatever. Uthoff, worsening of symptoms with heat and exercise. So I've actually seen this in a patient where they were taking a hot shower and then their symptoms of optic neuritis got worse. So they started to lose vision more rapidly, or they had worse pain with eye movements, that kind of thing. So the two, a little extra credit, optic neuritis phenomenon. If you're on a rotation, you're a med student, and you pull out a Pulfric phenomenon, it's like immediate honors for an ophthalmology rotation. You're going to get some funny looks, though, from the rest of us. All right, so anyway, we have a strong clinical suspicion that this patient has optic neuritis. What do we got to do? We got to get an MRI. All right, so what kind of MRI, you ask? Well, I'm going to try to make my radiology colleagues happy here. You want to get, obviously, an MRI with contrast because you need to be looking for a signal in the optic nerve. So a hyper-intense optic nerve on one side versus the other tells you, there's probably inflammation there. I think it's a flare signal. I don't know. That's really outside my area of expertise. I just kind of tell the radiologist what I'm looking for and let them do the sequences, right? I do know because I always have, when I have neuro cases that come up in clinic, I always have my attending neuro-ophthalmologist in the back of my head telling, orbits with fat suppression, Flannery, Dr. Flannery, orbits with fat suppression. Fat suppression because it allows you to take away the orbital fat and you can just, it's easier to see the optic nerve, I guess. I don't know. And then also, in addition to optic nerve inflammation, you're looking on the MRI for white matter lesions. Because an increase, if there's white matter lesions on the MRI, that increases that patient's 5, 10, 15-year risk of developing multiple sclerosis. I don't have the actual percentages in front of me. It is a significant increase though. So from if the MRI is clean, no white matter lesions, I want to say I think it's about a 20 to 25% chance that that patient, 15 years later will end up with multiple sclerosis. If there's one or more white matter lesions on the MRI, that risk goes up significantly, that the patient will end up with multiple sclerosis. So that's also what you're looking for. Signs of any white matter lesions that might increase that patient's risk for developing multiple sclerosis. And then there's treatment. So let's talk about treatment. So treatment of multiple sclerosis. I'm not opening up that can of worms. You do not want me treating your multiple sclerosis because that is way outside my wheelhouse. No. Treatment of optic neuritis. Let's talk about this because it is based on the optic neuritis treatment trial. I'm not going to come at you with a lot of trials in this series, in this knock knock. It's called Knock Knock Eye, for God's sake. Like, this is not a journal club, okay? I don't want it to be. Trust me, you don't want me running a journal club. Well, maybe you do. I don't know. But I'm not gonna. Anyway, the optic neuritis treatment trial, this is one of the few trials that I'll bring up just because it really does impact how we approach optic neuritis episodes. So the goal of this trial was to evaluate the role of steroids in treating a unilateral optic neuritis. So patients were randomly assigned to 3 groups. The first group received IV steroids. The second group received oral steroids. And the third sad little group received oral placebo. So the IV steroid group received, it was like 250 milligrams of IV methylprednisolone very frequently for like 3 days, and then followed by an oral taper. And what they found was that the IV steroid group recovered from their optic neuritis episode faster. But then after 3 years, there was no difference in visual recovery, of incidence of multiple sclerosis. Basically, they did just as well as the placebo group that received no treatment whatsoever. So the biggest improvement, the biggest benefit to the IV steroids was just faster recovery, which can be a big deal because optic neuritis, patients can have, pretty good vision, like our patient that I presented, maybe 20/30, 20/40. I've seen patients with hand motion vision from an optic neuritis episode. Pretty poor vision. So it's interesting to note that, IV steroids, that's the recommended treatment if you're going to treat optic neuritis. But in the end, steroids or not, IV steroids or not, they're still going to end up roughly the same visual acuity, which is actually really good. Like upwards of 90% of patients end up, either back at their baseline 20/20 or slightly worse, like 20/30. But they recover really well from optic neuritis episodes. The one group that was a little bit different was the oral steroid group. The group that got oral steroids actually had an increased incidence of developing multiple sclerosis after a number of years. I'm not sure. I think maybe it was 5 years, 10 years. Anyway, the point is, I'm doing my best here, you guys. This is good board review study for me because eventually I have to re-up my board certification. The point is, we never treat optic neuritis with oral steroids only. If you're going to treat it because either it's really severe vision loss and you want them to recover their vision, faster, then you treat with IV first, followed by an oral taper based on the optic neuritis treatment trial. There you go. Never just oral steroids. But also, the patient will do just fine with no treatment. So if a patient comes in because maybe it's been like 2 weeks that since they started losing vision, and you're like, oh, should I treat it at this point? Well, they would do just as well if you treat it or not at that point. So it's okay if optic neuritis does not get treated. The one thing to make sure of, though, is that you're dealing with a typical episode of optic neuritis. So here's the natural course of an optic neuritis episode. The vision can gradually get worse over days to up to about 2 weeks. By a month out, that vision should be stabilized or start to improve. Really, it should start to turn a corner and start getting a little bit better after about a month. If it's been a month and the patient has had no improvement, or it's starting to decline a little bit, or it's still, the vision's still declining, you need to think about other reasons beyond optic neuritis why this patient might be continuing to lose vision. So you're looking for weird, infectious diseases like syphilis or something, or maybe like leukemic infiltration of the optic nerve, or, it's very off the wall things. That's a situation where I would get on the phone with my neuro-ophthalmologist, as would many of you. So anyway, that's the typical course for just your regular run-of-the-mill episode of optic neuritis, even though optic neuritis is never run-of-the-mill, but anyway. So the big conclusions would be, don't start oral steroids alone for optic neuritis. We never treat it that way. Do not initiate treatment just with oral steroids alone. Regardless of what you see on the MRI, white matter lesions or not, there is an increased risk of that patient developing multiple sclerosis. That's another takeaway. Fat suppression. Don't forget that. I don't know if that's going to be helpful for you, but again, that little neuro-ophthalmologist, Dr. Thurtell, shout out Dr. Thurtell, that Australian guy back in my residency, always in the back of my head in his little Australian voice. He's doing a great job back there. So anyway, that's it. That's all I got for you guys. So let's see. Oh, I didn't do a don't do that eyeball tip of the week. Let's see. Don't. Well, there you go. I think I just did it. Don't treat optic neuritis with oral steroids. Look at that. We always run into a don't do that eyeball tip of the week, don't we? We get there eventually. Now, will that tip ever be useful to you, listener, watcher on this on YouTube? I don't know, but maybe you can regale your friends with this tale of woe regarding oral steroids for optic neuritis. I really think that's all I have on optic neuritis. I can't come up with anything else to do with that. So we're going to leave it at that. Give me your suggestions, you guys. Let me know what topics you want to. I don't want to hear anybody asking me for optic neuritis anymore. I can't give you any more information on this. It was a good topic. I'm not going to get into actual multiple sclerosis because I am not. I'm not the person for that. All right, that is a whole different disease that is outside my area of expertise. So ask your favorite social media neurologist for that one. But that was fun. That was a good review for me. And so I appreciated all the suggestions, all the people that wanted to hear about optic neuritis. And let me know what's next. Okay. I got a call week coming up. And so I'm going to be taking notes and keeping a log of all the patients I see, and maybe we'll, do a little thing on that. But yeah, thanks for stopping in, and we'll see you next week.
Knock, knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts, or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Hope you subscribe, leave a comment below. Let us know what you think.